these wise and wonderful words help me to remember that you are here individually. Your focus is on your daughter. What I'm going to tell you, and hopefully, Claude, I'm going to feedback off this one. Can you turn that one off? Yeah, thank you. Your focus is on your daughter. Over the years I've worked with Rett syndrome, I've met probably 400 or 500 girls, women, boys and men with Rett syndrome. And although each of those is special to me in my heart, what I've been able to do for them, but trying to focus on for you and individually to think about what I have to say can help you with your daughters. Bill's already alluded to the fact that I'm going to be here for the rest of the time. If you've got any particular questions about your daughter, your son, please come and see me. I'm here until Sunday morning, so I'm quite happy to do that. So what I'm going to be talking about, engagement and possibilities, hopefully what you're going to go away with are some tools that you can take back to your speech and language therapist, to your schools, to your teachers, to the people who are involved in your daughter's care, that will help you to look at the communication pathway with a new framework. So the content that I want to cover, if I can, understanding the need for speech and language therapy, the impact that Rett syndrome has on speech and language development. And I need to do that because I work from a kind of structural model, understanding any condition that I'm asked to support and work with. And then looking at the pathway for provision of speech and language therapy from engagement, assessment, and then the possibilities for intervention. And I want to talk a little bit about a project that I'm involved with some other clinicians that I met at the Rett syndrome conference in Europe at Maastricht 3 years ago. We're looking at trying to develop some consensus guidelines. Because the most difficult story that I hear is that families are faced with clinicians who don't know enough about Rett syndrome. Your daughter's diagnosed, you go to see a speech therapist, and you don't always get the best advice. They've never worked with somebody with Rett syndrome before. So my journey looked like a bit of a zigzag. I started off working back in my home on the Isle of Wight in 1972 as a newly qualified therapist, and not knowing anything at all about Rett syndrome. Interestingly though, as my life progressed and I got to know people in the disability field, I realised that there was a young lady with Rett syndrome that I'd known since I was about 8 years old, who, when I did her case history with her mum later in years, I realised that she lived just down the road from me. So she was my very first Linda, was the very first girl that I'd ever come across. But of course, at that point, we didn't know she was Rett syndrome. In 1981, I and my husband and our 2 boys left the Isle of Wight and went to live in Ontario. And I worked in a huge institution. I was the only speech therapist with 5,000 people with learning disabilities. And my learning curve was immense. And 1981, the beginning of my journey really, in a sense, because it was in the institution that I met a young lady called Jenny, who, as a young person, had been put into that kind of care. It was something that far back in time people did. They were advised by well-meaning pediatricians that their daughters needed to be looked after by somebody else, and they should get on with the rest of their life and their other children. And Jenny came to our attention in 1983, 1984, and we provided the usual kind of care that you might provide to somebody who had cerebral palsy, which is actually what her diagnosis was at the time. But no matter what we did, as clinicians, she continued to lose skills, and her parents were very angry with us as provision in the institution, and sued the institution. So we really struggled with what we needed to do. And in 1985, Patrick McLeod, geneticist, who's in British Columbia, Kathy's not in because she knows him well, he went to the first conference in Baltimore, met Dr. Rett, came back, and he was so excited because he said, I know what's wrong with Jenny. And when you know where you are, you know what pathway you're on, you've got a better idea of what to do. Except that the literature at that point was not very hopeful. But what Patrick and I did is to examine the population in the institution, and we found 15 other women who had the same clinical presentation as Jenny was presenting. So we then had a cohort of people that we would begin to follow. And so my focus on Rett syndrome, 1985 to 1996, when I returned to UK, it was part of my caseload. And in that time I met some wonderful women. I just want to tell you a story, a little story about Betty, who was an older woman. She was 42 years old when I met her. Her mum was in her early 80s. And she'd always believed that her daughter's disability was because she'd been a little bit rough with her when she was a child. Her crying and lots of her. She had not been, she felt, the kindest mum. So for 40 years, she lived with this sense of guilt that her daughter's disability was her fault. It was such a relief for us, geneticists, and myself, to be able to tell her that actually Betty had Rett syndrome. At the time I met her, Betty spent many hours in her day crying, very unhappy. She had very caring staff in a residential care home, but they really didn't know what to do with her. What they used to do was sing her nursery rhymes. I wasn't sure that I approved of that necessarily, but I went along with what they did. But through a program, which was really the only way that we could provide communication at that time, using simple choice making, what we discovered is that Betty, sorry, I seem to have lost my sound. No, I'm there. Betty is a 42-year-old woman, had heard all these nursery rhymes and children's stories, but what she liked was Daniel Steele's novels, which is such a change in her life. Through simple choice making, we were able to get her to choose what clothes she wanted to wear, what she wanted to eat, what colour her nail varnish was going to be, and just with those simple changes, Betty stopped crying. Her days were filled with things of her own choice, and she became a much happier woman. So at 42, we were able to bring about changes. But also, she began to feed herself again with some support. I read back in her institutional care records and found that she stopped feeding herself when she was 12 years old. But at 42, she regained that skill because of the way we were able to support her. So people would say to me, oh, she's too old to learn to do anything different. I never believe that. For those of you who've got older daughters, seen them through the run, it's always possible to bring about change. So focus on Rett syndrome in the institution and in community. In 1996, I moved back to England and worked in Maidstone as a manager of a speech and language therapy service. And I wasn't able to focus in the same way, but I met more and more women who've been in institutional care, who are now living in the community, and their staff groups needed to understand more about the condition and how to address that. In 1997, I moved back to my home on the Isle of Wight, and one of the first little girls who was referred to me with feeding difficulties was Poppy. I don't have photographs of any of these people, but I have them all in my head. Poppy, as a 10-month-old, was presenting with feeding difficulties, swallowing difficulties. But as soon as I saw her, and saw what she was doing with her hands to her mouth like this, I knew she had Rett syndrome. And I spent the next 4 or 5 years working with paediatricians on the Isle of Wight to educate them about it. None of them had ever come across a single case in their whole working life. So, although I'm a speech and language therapist, and my focus has been on that, in 2014, I'd lost my hearing, and I'm finding life very difficult to have one-to-one conversations with people. I decided to retire and move to Ireland.
Check 1, 2, 3.
And here I am. So my journey is a bit of a zigzag to get here today. I'm just going to add a little story in because actually Jill knows me. I don't know what year it was, but it was a presentation that I did at a conference in the United States, possibly one of the URSA conferences. And I asked if they had any tape recordings of the girls and women who still Joanne was one. But Bill's story was that Joanne spoke in the car when you took her for her trial on a regular basis. And he sent me this tape recorder, which I still have. Now, it's quite hard to find a tape recorder nowadays, but I still have it to play. And first of all, I've never heard of a girl or a woman with Rett syndrome talking before, but also not with an Australian accent. It's a very precious piece. It's in my office, in my move to Ireland. It's still with me, and I still have Joanne's tape and her photos. So I think you get the sense that Rett syndrome is very important to me. It's my passion. It's the centre of what I do, of my reason to get up in the morning. And I discovered this recently, that there's this lovely Japanese word called ikigai, that it's just that. If you have a focus in your life, it's what you love, what the world needs, what you can be paid for. I don't get paid for my work, by the way, but what I'm good at. And I hope that what I'm able to do today is, in a few more minutes, is to give you some sense of what I've learned in the 30 years of working in Rett syndrome. So we know that Rett syndrome is not something that suddenly appears at 6 months or 2 years. It's caused by the MECP2 gene being different, and that impacts on the way that the brain develops from conception, and particularly in the first years, the first months postnatally, after the girl falls the way that the brain is shaped and structured. And those brain differences affect a number of systems, both thinking and learning, speaking. Many of the girls suffer with sensory overload. They have mood and emotional lability. Their independent movement. And this wonderful word, which you probably have all heard either as dyspraxia or apraxia, the inability to actually perform a movement when you want to. And then changes in the autonomic nervous system, with breathing, heart function, and the other part of speech therapy work, which is the chewing and swallowing. I'm not touching on that today because that's a whole other aspect of the work that I've done with people in the past. But we know Rett syndrome is a complex and unique disorder, and unfortunately there are very few speech and language therapists who have the opportunities that I have had to focus in on Rett syndrome. What we know is, the literature will always say this, the first 12 months of life appear to be normal, but there's a chap in Europe who's been doing research on those early developmental stages of girls' lives, and we know that there are actually differences in the first year of life, which if you are skilled enough, you will be able to pick those out. So when parents start to become concerned about their daughter's development, if somebody knew that they had Rett syndrome, they would see what those differences were. But Peter's done a retrospective work to look back at the developmental patterns and knows that there are changes and differences in the way the girls present even in the earlier times. Although we say they appear to be following normal milestones, they come. Quite often they're described as very good babies, maybe passive. Some of them may be crying a whole lot more than others. But then what will happen though, because you appear to have a normal daughter and you interact with her every day, you won't be speaking to her, you would be talking to her as if she was any other child. You wouldn't be thinking about her disability. But we do know that some children differ significantly in their early stages. Others continue to develop language skills, including the use of first words and short phrases, and a few speak in sentences. Some of the work I've done in Ireland for Rett syndrome in the Irish Rett Syndrome Association, I've done clinics for them. And at one of those clinic sessions, a little girl came up. I'd seen her running around with a lot of the other siblings, and she came up and stood next to me. So I said, hello, and how are you? And she said, I'm fine. My name's Anya. I had no idea this little girl had Rett syndrome. She was the first girl that I'd heard speak full sentences, and she really does have full access to language. But in my mind, what I've learned is that we have a spectrum of disorder, the way that it presents. I can't say Rett syndrome is this, because it's a whole lot of different things. The way that the girls learn, grow, develop over time, we have to go with each person as an individual. I can't, in my mind, think, okay, Rett syndrome means this. It's simple. It isn't. It's very different. I haven't had the chance yet to meet many of the daughters. I'm saying daughters. Are there any families with a boy? No. Okay, so So I always feel bad saying girls, boys, men, women, it's a mouthful. So if I say girls, I'm okay today. One of the things that strikes me is that a lot of the games we play with children when they first start to develop are social games that require the girl to hold out her hand. And I've seen actually photographs and videos now that show that some of the girls have difficulties with those kind of games. What happens is that the parent has to hold the hand in position, thinking that could actually be almost like a first significant difference, which if a health visitor or a other professional was aware that that was problematic, you might start to follow a little bit more literally. Perhaps problem of being independent in motor skills could be a significant marker. But what we know is that even if a girl doesn't talk or has lost her talking skills, she retains her social skills and her ability to follow language in conversations. One of the funniest ones that I realised about this was two old women in a community care setting in Ottawa when I was working in Canada. And the two staff members were talking about getting their hair coloured, fancying themselves up for a wedding at the weekend. And Carol got very excited. They hadn't realised quite what Carol was following in conversation beforehand. She sat with them, they were very kind and let her sit with a coffee break. But the fact is she got excited and was leaning forward to them, the way the girls do that intense rocking and looking right into their eyes. And one of them said, "Are you trying to tell me that you want your hair coloured too?" And I thought she was going to explode because she was so excited that somebody actually understood what she was trying to tell in a very limited way. So following conversations, there are lots of stories, I'm sure you've all got that where you know your daughter understood what was going on. This is a sad bit that we all have to deal with, but loss of skills, the regression phase, when words disappear. So you could be talking to your daughter, but she doesn't give you the feedback. One of the hardest parts for me in working with families with young children is to remind the parents that they need to be talking to their daughters. If somebody doesn't follow you back with a conversation, doesn't give you the feedback, the hard part is for you to then have a conversation because it's one-sided. It's a bit like playing darts. What we want is ping pong, where the ball is going backwards and forwards between the two people, rather than one person doing all the talking and not the other one not getting a chance to respond. So we know the girls need to be spoken to in order to develop their vocabulary. I remember one of the first mums in Ontario that I spoke to about this, and she said she felt she had to go back home and apologise to her daughter that she hadn't realised that she understood. And so she had to go through this, for her, a very difficult conversation to say sorry to Erin that she had not been speaking to her. And now she realised in fact how important that was. It's not natural, it's not the way we normally have conversations with people, but you can adjust. And if you feel difficult about it, then reading is a very simple way to provide that. Sitting with your daughter, reading a book, it's a great way to introduce recovery. And you can choose any books you like, including Daniel Steele, if that's the So the other part that we know, and there's some interesting research in this, not particularly for Rett syndrome, but the importance of hand use for learning concepts, for developing understanding of how the world functions. If you're a child who can't play with objects, and many of the girls don't do that, how do you know what sticky means? How do you know what heavy means if you haven't had that hand function opportunity? And this isn't speech therapy. I look at the child holistically, and I have to think about the ways that we can adapt play in those early years to make sure that the girls do develop the concepts. The social withdrawal, and for many girls, the misdiagnosis of autism is a difficult time in people's lives. And that's often at the time when a girl may be referred to a speech therapist. If she comes with a diagnosis of autism, what you do in autism is you have a particular pathway to follow. And so the speech therapist might start to work in that way, as they would with a person who's autistic. But it doesn't work because the person is also not necessarily, it's the wrong diagnosis. What we know about Rett syndrome, the girls show a strong desire to communicate. Their social gaze, the way that they interact with people, they rarely use spoken words or use sounds meaningfully, but they can recognise the world if they're presented to them in a way that's meaningful in their daily lives. They may not have had the opportunity to explore and play in their environment, and they may understand what's said, but they don't have a way to demonstrate that they've understood. And that's difficult because if I'm a speech and language therapist who's referred a child for assessment, one of the things I will need to do is follow through with some kind of assessment procedure to find out what language the person understands, what words they understand, how they can process sentences, how those order of, if I say the girl pushed the boy pushed the girl, the sentence contains the same words but has completely different meaning. If I'm looking at my toolkit as a therapist working with regular children, I would never dream of using those same tools with the girl with Rett syndrome, because if I asked her to say, where's the dolly, she might look at it. I can take that as a meaningful response. But if I say, put the dolly on the chair, fail. She can't do it because she's not able to reach out, pick up the doll and put it on. Doesn't mean to say she didn't hear, understand it, process that language, and know what those words mean. So I've got to find different ways of doing assessment. And I think perhaps just I'm bold enough. It's something I was talking to Sherry about last night, that sometimes when we're doing assessment, we can't always go to evidence-based to find what the practice should be. We develop our own pathways for doing work, and in Rett syndrome it's one of those things where we've had to do that because there is very little literature that will tell us how to work with somebody with Rett syndrome. Will you shout at me time-wise? Yeah. Most importantly, when the girls may be understanding, this is important. I want you to really think about this. A lot of parents still, and carers, will talk about the girl in front of her. Right? We must start, those words are going in and being processed. That she can see, think, hear, love, laugh, feel, and hurt. And sometimes the words we say when we're describing other people and their disabilities, you have to be so wary of that. You need to have a conversation about her, but should you be doing that, having a conversation about her, without her? How do you say things in a respectful way in front of those other professionals? I see some nodding, that's me, you guys do it. We know some work that Teresa Bartolotta in the States has done, some really nice research about the different forms of communication that the girls use. So without words, there are many other ways to communicate. I'm not hearing words back from you, but I'm talking and I can see you nodding, you're following me, you're looking at me while I'm talking. Nice one, nice head nod. And research that's been done at Montefiore, finally somebody said the cognitive abilities of the girls are underestimated. That research has come about because of access to assessment through eye gaze, looking at how the girls interact with the world in a different way using the eye gaze technology, which hopefully you will all have a chance to try out and see how that is, how that will work. Interesting, parents always report that their daughters understand at a higher level than the professionals. And I think, and again, something Sharon and I were talking about, which is how do you launch into an assessment with somebody that you don't know? You meet them for the first time. You can't just coldly start their assessment process. You have to get to know the person first. So the finding that parents believe their girls understand more than the professionals do is simply that the professionals may start from that beginning point without really taking the time to get to know the girl first. But the biggest problem is the motor planning and understanding what apraxia is. I just got momentarily distracted by it. Wow, very scary. Okay, so the research, this is the bit that's really important now, because when I started off we didn't have that research, but the research that's being carried out now worldwide is showing us what parents and a few others have believed all along, that girls with Rett syndrome do understand. They look at objects and then go to people. There's some research that's specifically at that, looking at simple vocabulary development. They respond to familiar phrases in context. But they can't manipulate toys, so assessment using the traditional ways of assessment are problematic. And they can demonstrate understanding so long as the response that's required is not And the evidence is difficult to replicate, which means you can do it one day, but you can't necessarily do it the next day. And that apraxia, that's what gets in the way. But I met a girl in Ireland who had on her individual education plan a target that she would hit a button in the morning to participate in registration, and she had to do it 80% of the time. That was the criteria they selected. She'd been doing the same goal on her daily experience for 8 years because she could never meet that 80% target. I'm thinking, why would somebody go on to use a switch, to make a girl use a switch when there may be other ways that she could be participating in that process? It's a lack of understanding that this is not necessarily attainable. So we know this. And I've got two here, I'm just going to very quickly go through, but eyes have it. The eyes are way into this world for the girls. We shouldn't expect them to be doing things with their voices, with their speaking, with their hands. Their eyes tell us everything. Look into her eyes speak louder than her voice ever will. And I'm going to quote Alan Percy. He says that eyes have it. And he goes to the soul, take us to cherished places within our heart. You all know this. Your daughter tells you things with her eyes in a way that you interpret. But eye gaze technology is giving us real answers about independent thinking, something that we, even 10 years ago, we didn't really have access to. So in assessment and intervention, the things I need to know, this is basically what I'll be looking at if I'm gathering information, the age and the stage of Rett syndrome, if they use hand skills, communication tools, what the parental care belief of their understanding is, and then I would look at their means, reasons, and opportunities. I put those in bold simply because that's a very simple thing to be thinking about. Means of communication, reasons to communicate, and what opportunities they have to communicate. When we do assessment, silly cartoon, but oops, this button's quite like that. The idea of we set the task to do an assessment, but actually the tasks are set up only, to be fair, for a certain group of people. So who's going to climb the tree? Well, the penguin certainly will never do it. And normally, no matter how hard they try, no matter how much they wanted to, they would never be able to carry out that task. Part of eye gaze technology, which we can learn more about, and I hope that Maz and the other over here, you'll be able to show us this. There's something called the eye tracker, which can be used, sorry, I'm too quick on this button. The eye tracker is part of the Toby toolkit and can be used for looking at. I'm looking at Claude and thinking, he's not doing anything. No, it's not me. His hands.
Must be your eyes.
Oh, dear. Anyway, eye tracking, which is part of the Toby toolkit, can be used for assessment purposes, and I can carry that out both for informal and formal assessment. We've got some adaptation of, for example, a formal vocabulary test, something that we would do with all children. It's four pictures on a page. You want to know where's the apple, but equally you could be saying which one's red, which one can you eat, and the girl would look at it. So I can assess that language simply by what her eyes are looking at on the computer screen, and the computer records what she's looking at. It's not me interpreting and thinking, oh, she knows that. The computer does it for us and provides hotspots of information that says this is where the girl's looking and focusing. So eye gaze technology can be used for communication, but also for these kind of formal assessments. This provides you with some of the evidence that you might need for admission into certain programs, certain parts of education. There was a webinar that I did with my colleague from Toby in the UK, and I've got a link for them if anybody's interested, which shows how the Toby eye gaze can be used, the tracker can be used for those assessment purposes. I'll give you the link if you're interested. Eye tracker and assessment. Okay, I will flip that one. Actually, no, let me go back for a minute, because Olive, the little girl here, is a twin, and her sister doesn't have Rett syndrome, but it's wonderful to see these two girls working. And I'm just curious, are they twins? Because I just think the way that the twin sister works with Olive is just wonderful. She is her voice in many respects. She knows her sister very well and will often tell her mum, Janie, what it is that Olive wants. But she also, even before she was 2 years old, was doing hand support for her sister to access an iPad. It was something that Tilda could do, but Olive couldn't. But Tilda knew instinctively how to give her the hand support to make it work. It's wonderful to see them. But this is another way of assessment, and this was a webinar presented fairly recently. There is a group at Vanderbilt University who are taking something called event-related potentials. And that's highfalutin language for taking brain signals to register what it is that the brain is thinking about or doing. And the goals of their study are related to what I said already. That you can't use standardized psychometric assessments because they require hand use. They're not sufficiently sensitive to capture the full range of knowledge that you need to know about for Rett syndrome. And so they developed this new way of assessment for differentiating speech from non-speech. That was one part of their research. The second part was the auditory learning without visual cues to see what kind of memory the girls were accessing and recognizing names. They simply, all the girl is required to do is to sit with, I'm saying simply, but with a set of electrodes on the head. So it's not eye gaze, but a whole different way of doing assessment, which we should be tapping into other aspects of technology that can help with assessment. So I'm very interested to see the results of this. They're in the very early stages of this research. So, possibilities for intervention. There is a study, a program, a project that was done in the UK for Rett UK called Communication for Involvement. That's available on the Rett UK website. And we gather information about communication skills through the process of engagement, how I would spend time to get to know someone. So Jane Jones and Sue Thurman, two British speech and language therapists, wrote a toolkit to help parents and professionals increase the engagement of girls and women with Rett syndrome. Engagement is not, I like Kathy's definition and kind of play on words about what words meant. Engagement was when you got the ring on your finger, right? We should put that one into your collection. Engagement now is about the relationship between two people and the idea of somebody being disengaged, not with you. Whether they're a passive observer, they can see what's going on in conversations, but they're not able to participate. They may be able to participate in a limited way in the way that Carol did when people were talking about having their hair coloured. To be an active contributor, you have to have access to the tools for communication, some way by which your messages, your thoughts can be conveyed to another person. So there's 4 levels. Think about that even in itself, where your daughter fits into that. What is her level of engagement? And Sue and Jane work from this place, and I found this nice little cartoon of the seashells. The idea that the girls are unique and individual. Although they're all seashells, but each one has got their own patterns, their own colours, their own size and shape, which makes them special. And I need to find out what that specialism is within each child, that uniqueness. So I have to begin with strategies that help me find out more about the person and to document those findings in a consistent manner. So what I've done is designed a form, and this is the beginnings of our consensus guidelines. I've designed a form that allows me as a clinician to gather that kind of information so that I can write a holistic report about the range of things the girls can do. And to do that, there are strategies, things that I use primarily, the profiling and information gathering, sensory and creative activities, and augmentative and alternative communication. I'm not going to get into that because my friend here, Mary Louise, is going to be talking about AAC in more detail. There's some other aspects of information communication communication strategies for advocacy and person-centered thinking. Each of these areas alone could be a whole day's workshop, 2 or 3 days workshop if I was to spend time doing more training for you. We'll think about that. And communicating about health. Do you use health passports? If your daughters were ever admitted into hospital? No, I'm looking, this is not something you know about. It's a very important document to put together. I can share with you the format that's used in the UK for doing that. So gathering, profiling and gathering information, communication passports, all about me books. Do you use those? Yeah? Yes. Good. Personal dictionary. So all about me, just the favourite things. This is what you believe about your daughter. Not necessarily what she would tell you, but it's a starting point. It's about your belief about your daughter. And gathering that together, writing it up in a nice format, putting on a CD, some way of sharing it. Communication passport, we started off in Scotland. Again, there's different formats for this, the way of putting it together, but it's a document that is actually owned by the girl, written in the first person, although you would be the primary person that is putting the information. It can be in a booklet, a CD, a photograph album. Now this one, the personal dictionary, is I think probably other people may call this process something else, but what I would look at is the girl may be capable of fairly consistently making a sound, making a movement, something that you as a family know, you believe, you understand what that means. And so recording that in the format of this dictionary and sharing that with other people, the kind of care response. Thank you. I did a lot of work with a lady called Linda, who happens to be that very first girl that I ever met, and I had seen a photograph of her with her long black plaits as a child. But she did something very special that took her staff knew and were able to interpret. She could walk, and she would walk in the kitchen and stand near one of the cupboards. She knew in that cupboard that's where the hot chocolate was. Intensive interaction as a process. The practitioner that I'm familiar with, Dave Hewitt, is based in UK. I've already forgotten Mary Lou's told me who the there is an Australian person who has the kind of responsibility for training and information about intensive interaction. Individualised sensory environments. Karen Bunning is a speech and language therapist who spends a lot of time looking at how you find out what people like and don't like using a sensory approach. It's a fantastic way to spend time and be with a person, to actually get to know them. Most importantly, this is, instead of you doing all the talking, you need to listen. I like Dalai Lama sometimes is important, but be an owl. So owl, O-W-L, observe, wait, and listen. It hasn't got anything about you talking in that. It's you sitting back and being an owl. Very important way to find out what a person is capable of doing. So watching the girls, listening to the sounds, waiting for that response. AAC, just very quickly, the kind of things that you could be using, objects of reference, talking mats. I won't read all through it, but the last one, the eye gaze controller computers, I'll come back to that because it's such exciting technology. In 2011, Hector and I did a study looking at more than 122 girls who were assessed in the clinics that were offered in the NHS and through schools in UK. Of the 122 girls who were assessed as part of this pilot project, only 2 were not able to engage with technology. That's a phenomenal result. It's out there. That's data that's been shared at a conference publicly and through my professional journal. I can't bear the thought that the speech therapist is saying girls with Rett syndrome can't use eye gaze, because that's not true. This is a starting point. So Hector and I together, it's a very important piece of work that I'm really proud to have been involved with. I already mentioned the study at Montefiore, and Alexander Ducek has made this very bold statement, said that the girls are underestimated. We should find new ways of working with them, that the eye gaze technology will give us ways to actually carry out this assessment to look at independently and assessing their abilities. So eye gaze devices I think I probably need to finish. If this was your communication device, we've got to look at what information we would put into a communication device. How do you know what the most important words are? If you only had 12 words that you could say, what would you choose to put in there? Sherry and I were laughing about this last night, because sometimes as adults there are some words that we might want to say to other people but we would never think about putting into a communication device. So the closest I could get to was stop. Yes. So if I had 12, those are important. They give me the chance to control other people. That's often what communication is about. Yes. What's important though, and we mustn't forget about this, that learning any new system takes us time. For all of us, learning a new task. We expect we can find a girl with a book covered in symbols and she'll know how to do it. But she won't. She has to be shown how to do it. We have to model that communication device. We need to demonstrate to her how these words and pictures are going to be used. So competency takes time, and schools should be aware of that. So if I presented you with this, which is a two-step colour-coded encoding device of communication, you wouldn't have a clue. None of you would have a clue as to where to start with that. So much of what happens today, tomorrow, next week is up to you. One small step on the journey is more powerful than you can ever imagine. You're the parents, you know your daughter better than anybody else. Don't let the speech and language therapist bully you into ways of working that you aren't comfortable with. Your big journey starts with a small step. And you don't have to start with X. Simple choices using objects. This was a favourite for Betty, choosing what colour her nails were going to be painted. If you ask questions requiring a yes or no, one of the mums, who I don't see here, but she did this beautifully with her daughter last night, I was looking at it. She does this and developed a system for giving yes/no responses. The speech therapist thinks that it's not a good idea. Now, I quite like this. I spent a whole day at a conference in Toronto pretending that I couldn't speak and only giving yes/no responses. People need to know how to ask the right kind of questions to get a yes/no response. You can draw your own journey. Where you start is up to you. The idea that there is a journey you're all on a different place on that journey. Some of you far more advanced and some just beginning. And I love the way that parents share information with each other. And one way that I help with that, although I am now semi-retired, what I have are 2 pages on Facebook where people can get to know each other, where they can pose questions. And I have the links for these, but the name of the 2 pages, I can, again, while we're here over the weekend, I can show you what these look like. But 2 groups, one specifically for families and therapists and teachers. It has files which have been written by lots of different people that you can access, download, share with your schools. But it's about friendship and support. I think that's such an important thing. You know, you're members of the Rett family. I sit on the outside, but I don't really know what life is like from your perspective. But what I have now is a collection of 60 professionals worldwide who are interested in doing more research on communication. And we hope that that's where our consensus guidelines are going to be coming from. But if you've got any questions for me, then this is the best way to do it. I will talk to you over the weekend, but that's my own personal